Okay, thank you very much again, Dr. Bancalari, and thank you, Dr. K. So we'll start with the questions. I will start with the first question to Dr. Bancalari about the strategies of the lung ventilation. So most of us using the volume targeted plus assist control, and Dr. Kate is using SIMV. And it's a question for both of you. Is there any difference or is there a preference? Dr. Kate suggested it depends on the baby physiology. So, what do you think? Well, it's a question for both of you. But here we are using assist control plus volume targeted or volume guarantee. Is there any way we can define that that one is better than this one?
Hey, do you want to start?
Anyone of you start?
Okay. Okay.
Yeah.
Well, I think that if you go by the evidence on volume targeted ventilation, you have all the support to use volume targeted because again, the suggestion is that you can reduce duration of ventilation and that you can maybe reduce bronchopulmonary dysplasia. As I mentioned, we are not convinced about the strengths of the evidence on BPV. And on the other hand, we have been using volume targeting for more than 20 years. We actually helped some of the companies to develop volume targeting, and Dr. Gerhardt was part of our members. So it's not that we are uncomfortable because we don't have experience. We are uncomfortable because every time we use it, we see that it's a strategy that requires much more knowledge, much more certainty in terms of what each ventilator. We don't have time to go into that, but there are all sorts of different algorithms, different systems that produce volume targeted. None of these things have been evaluated in any systematic way. So we are very worried. And again, the first equipment, what algorithm the equipment is using, accuracy of the flow sensor are crucial. If those things are not working, it can do much more harm than good. And the main limitation in our judgment is what tidal volume do you use? If you are targeting a tidal volume that is insufficient for a certain patient, what happens? The baby will start making more effort, will move a tidal volume larger than the one you are setting, and the ventilator will win the pressure completely because we'll think that the baby is getting a tidal volume that is excessive. So you are targeting 5. This is a chronic lunger who needs a tidal volume of 6 or 7. He increases his effort to get that 6 or 7, and the peak pressures are win. So this is, and you see the baby struggling, okay, to breathe. All the effort has been essentially passed to the baby. No good situation. I think it's very good. It's very poor. Now, the other side is that if you are using a tidal volume that is higher than what the baby requires, usually you will lower the CO2 below the apneic threshold, essentially. The baby will be very happy, will not be breathing because he will be getting a tidal volume that is higher than what he is set for. And essentially, you are passing all the responsibilities to the ventilator. We see this happening all the time in our own unit with patients. And the tidal volume that now may be 5 or 6, tomorrow may be 7 or 4, what the baby needs. These are dynamic changes, as Dr. Gibbs explained very nicely. So it requires much more knowledge, much more being on top and perfect equipment to achieve this. And we feel that this is not easy to achieve in most neonatal ICU. So that's why we don't use it routinely on everybody.
And Dr. Gibbs,
I just have a question to Dr. Bancalari about the use of high frequency as a primary mode in effort to decrease the BPD. As you mentioned, prior to 2000, we used to use high frequency as a primary mode to thinking that that's to decrease BPD. Then came along the Hi-Fi study, which is showed like increase the IBH grade 3 and grade 4, and if you do that as a primary goal. Now we recently listened to a presentation from University of Iowa. They use high frequency as a primary mode, but they use a jet ventilator. So my question to you is that do you have any comment about any advantage of using the jet ventilator over the high frequency oscillator ventilator in the BPD prevention strategy?
Yeah, we used jet ventilators many years ago, but at this we have not used it now in many years. So we really don't have experience to tell you what we do and how do we manage the decision of one versus the other. In our judgment, there is no good control trial comparing high frequency jet with high frequency oscillatory ventilator to make this decision. And as I mentioned, and I showed the data from Ulrich Thome, we don't think that the evidence in recent years is strong enough to recommend high frequency oscillation routinely in all preterm infants. And the main reason is that high frequency oscillation is a very effective strategy to wash out CO2. So in our center, we use it usually as a rescue in babies where the CO2 is going up and we're not comfortable escalating the peak inspiratory pressures. But in terms of oxygenation, if anything, usually you see a loss of oxygenation. And that's why most of the times you have to use high mean airway pressures when you switch from conventional to high frequency. Now, the main reason why we don't use high frequency is because our philosophy is to use mechanical ventilation to support the spontaneous breathing of the patient. And the babies don't breathe at 10 hertz or 15 hertz. So there is no way that you can do any synchronization or anything when you're using high frequency. Usually you lower the CO2 below the breathing threshold of the baby. So most of the kids get apneic when you're using high frequency. And we think that most of the evidence, as I mentioned in the first talk, is that the best thing you can do is to let your patient breathe and use your ventilator to support, to amplify the breathing. You cannot do that with high frequency. So that's why we prefer to use routinely conventional and not high frequency. I would be very interested in hearing Dr. Gibbs on her experience both on volume targeting and on high frequency, because again, in a children's hospital, they have a completely different type of population.
Yes, Dr. Gibbs.
So I'll say in our typical small baby unit, so our hospital at University of Pennsylvania is our inborn unit. We do use volume targeted for the ELBW infants. The Draeger baby log, the microprocessor with the latest iterations, is pretty sophisticated, and you can get down to low tidal volume. So I would say that's the general strategy. And then we do use jet. It's generally, if there's PIE, we don't use it on everyone. So I think jets, if there's interstitial emphysema, we'll move to the jet or air leak. And then the oscillator is certainly used for the severe respiratory failure in those infants. So I would say it's a mix. And I think if there's a significant leak, then you'll move to pressure control in the small one. So we use all four. At CHOP, I'll say the patient population is all outborn largely. The special delivery unit doesn't deliver. We don't have many inborn small babies. And so the patients are quite sick. But I'll say generally, again, we're using volume target.
Question, Dr. Gibbs, about your case presentation where you have a patient admitted to your unit and PRVC and 100%, and then you switch to SIMV, and then you have successfully decreased the oxygen to 40 or 60%. Now, what's your explanation to this? Because we're thinking about PRVC is the more synchronized and the more patient-triggered ventilation, where SIMV is only trying to synchronize. So what's the explanation of this drop in the oxygen requirement when we move from PRVC to SIMV?
So I don't think it's necessarily PRVC alone. I think it's the fact that we frequently will get children in using the small baby strategy of lower tidal volumes, higher rates. And their disease is just so heterogeneous that their lungs need that higher tidal volume and then the longer expiratory time to really get their mechanics into an ideal place. I think that's probably where we see the impact is larger. We don't use PRBC because, like I said, we have the Draeger baby logs. And I'll just say that from our perspective, the ventilator for these patients is just is what matches them. I don't have anything against PRBC in itself, other than we don't have the ventilators that have those.
So you don't use NAVA ventilation of those older babies on it.
And I'll say the other element of PRBC is my recollection, having used it historically, is it's really an assist control mode. So you've got one eye time. That could be different on different modes. But again, that's why we move away from assist control as a universal approach, is because you then are only delivering one inspiratory time. For NAVA, there are no data on NAVA in severe BPD, so we're going to try and contribute to the field for that. Eric Jensen has an active research study planning to do crossover NAVA to conventional ventilation, and study that and hopefully contribute to that. Because there are no data. I would say that at our recent collaborative meeting, there are centers that are using NAVA in BPD. But I think it remains to be seen whether or not it's a strategy that meets their needs.
I have two questions for Dr. Gibbs. First is there any other way to estimate the required PEEP other than bronchoscopy?
In terms of identifying optimal PEEP, we'll use the ventilator graphics. So the flow volume and pressure volume curves, we'll use that, and how open is the patient on X-ray? How are they synchronizing with the ventilator? The kind of overall state to find optimal PEEP. I think for large airway disease, direct visualization of the airway and a dynamic airway evaluation is incredibly helpful, because you can see at a PEEP of 17, you're ameliorating that collapse. For small airway disease, obviously they're not going to get down, and that's small airway disease is where finding the optimal PEEP is that much more challenging.
There's another question that I think this is for both Dr. Bancalari and Dr. Gibbs, that for BPD, other than ventilation, what we discussed, what are the uses and what are the advantages of diuretics and bronchodilators or any adjunct therapy? How big believer you both are on this, especially the diuretics?
So diuretics are incredibly commonly used in BPD. Nick Bammett is another one of our physician scientists who has is funded through the NIH to actually study the pharmacokinetics and dynamics of furosemide in BPD. And so I'm excited to see those results over time. Certainly, we use them. There's significant diuretic use. I think the challenge becomes that the kidneys are smarter than we are. And then you get tolerance to the therapy. So I think there absolutely is a role. I think it's a matter of then what response are you for, and ensuring that you're actually seeing a response.
Dr. Bancalari?
Yeah, we have gone through different phases with the use of diuretics and the bronchodilators. Many years ago, we used to have all our patients on chronic diuretics, and after realizing how many complications we can induce with that, and the evidence also became much more clear in the literature, we have become much more conservative with the use of diuretics, and we use them only when there is clear evidence of pulmonary edema, and usually we indicate them for 2 or 3 days, restrict fluids, take any of the other measures to improve the edema, and then stop them. The complications, again, is calcium loss, nephrocalcinosis. They all develop a significant metabolic alkalosis that ends up producing more depression of respiratory drive. So we are very reluctant to use chronic diuretics. We use them only acutely for specific indications. And with bronchodilators, pretty much the same. If you keep a baby on bronchodilators, you will pretty soon have tachyphylaxis. They don't respond anymore, and all you will see is the tachycardia and the side effects of the bronchodilator. So We do use them, but only during acute episodes of deterioration and clear evidence of airway obstruction, especially clear evidence of response. I think that there's nothing wrong if you see that a baby is struggling, is having wheezing, the CO2 is going up, try diuretics by all means and see. If you see a response, you can see, looking at the graphs in the ventilator, the way Dr. Gibbs showed in her patients, and looking at the gases and so on, if there is a response, you can continue. But if you don't see a response, keeping them on prolonged chronic medications most of the times does more harm than good.
Yes, some couple of questions about caffeine for Dr. Bancalari.
Go ahead.
One about any difference between IV caffeine versus oral caffeine in the start. And the other question is that when to stop caffeine.
Yes. So in terms of IV versus oral, one of the beauties is that caffeine can be given either way, and you can achieve levels very nicely also with oral caffeine. So what matters essentially is how much you are giving and not how you give it. One comment I would like to make is that most of the literature suggests that you don't have to measure levels with caffeine. You just watch the baby, and if the baby has apnea, you just give a little bit more. If it doesn't, you just keep the same dose. We think that is the wrong approach. Like any other medication, especially in neonates, there is a tremendous variability in caffeine levels in preterm infants. In the same baby, as they mature, they clearly metabolize caffeine much more effectively and the levels go down. So we do measure levels and very frequently find that the levels are way too low and we have to increase. And sometimes we are surprised because the levels are higher than what we would like to do. So I think that especially if you are using oral caffeine, probably is wise if you have the possibility to measure levels and make sure that the baby is absorbing it. The other question was
when to stop caffeine.
When to stop the caffeine? Yes, that, as I mentioned, that is a question that is still open. Most of the times we start weaning caffeine around 32, 34 weeks of corrected age. And if the baby doesn't have any significant apnea or bradycardia, we continue to wean until we stop the caffeine before the baby goes home. But now Carl Hunt and his group, who has been doing studies on control of breathing for many, many years, is doing the study that is supported by NIH, because they have done much closer monitoring, and they have described that a good number of these babies continue to have apneic episodes and desaturations after 34, 36 weeks. So they are doing this prospective randomized trial where they are discharging some babies on caffeine, monitoring them carefully at home, versus the control group where the caffeine is stopped by the clinicians earlier. And we'll have to wait until those results are out to answer more precisely the question, when should we stop caffeine?
So just, I know we are running late, but just one or two questions. Dr. K, there is one question about of course, the mode of ventilation is very high, but even in the cases of the BPD, we never use that high beep. So can you elaborate again the TAN beep or the pressure of that much high?
Yeah, I think we are kind of known for using robust amounts of PEEP. And I think that the consequence of that is in some patients, we've now seen this very severe lymphatic dysfunction, and it may or may not be associated, honestly, with the PEEP. The other disclosure is that we get the most severe of the most severe patients. And so these patients have incredibly distorted lung architecture. And so I would say most of the patients right now in the unit are on a PEEP anywhere from 10 to 14. But if we've got a patient on a PEEP of 7 and 8, we're excited because we're moving towards extubation. So they just, for a period of time, it does appear that to achieve the opening up those floppy, large and distal airways, they do seem to need more PEEP than they certainly needed when they were much smaller. We don't use that much PEEP in the ELBW infants by any stretch.
Okay, Dr. Aiman, do you have any further questions?
We have one question about any risk of oral caffeine in necrotizing enterocolitis, in causing necrotitis in this.
Yeah, there is no data to suggest that oral caffeine will have a higher incidence of NEC. But since they asked the question, it's interesting because the trial that was used by FDA to approve caffeine use, again, included only, I think, were 60 or 70 patients, and there was a larger number of babies in the caffeine developed NEC than in the other. It was not significant, so FDA went on and approved the use of caffeine. Now, the good thing is that all the others done afterwards, including the CAP trial with 2006 patients, have not shown any evidence that caffeine is associated with NEC. So I think that that is a risk that doesn't seem to be there with caffeine.
Thank you.
So that's all. Yeah.